Good evening. Welcome. Thank you all for coming. This is a joint meeting and public hearing of the Amherst Select Board, the Pelham Select Board, and the Regional School Committee. Some Regional School Committee members are still on their way. My name is Stephanie O'Keefe, and I am chair of the Amherst Select Board. And I would ask my fellow chairs, if they have a quorum, to call their meetings to order at 6:44. And let's see. This meeting is being recorded by Amherst Media and is going to be rebroadcast over the next several days. As soon as that broadcast schedule is available, we will make that available on the town website, the school website, and in other places. All right, at this time, I would like to open this public hearing at 6:44 p.m. This hearing is being held pursuant to Massachusetts General Laws, Chapter 32B, Section 11E. In an effort to reduce health insurance costs, the Amherst Pelham Regional School Committee, the Town of Pelham, and the Town of Amherst are considering revoking their acceptance of that statute, thereby removing retired teachers from health coverage through the Group Insurance Commission, GIC, and returning them to coverage through the Amherst Pelham Health Claims Trust. The purpose of tonight's hearing is to inform affected retired teachers and the public of our intent to submit the matter to a vote by our respective authorities. For the Regional School District retirees, that authority is the Amherst Pelham Regional School Committee. For Amherst Elementary School retirees, that authority is the Amherst Select Board. And for Pelham Elementary School retirees, that authority is the Pelham Select Board. At the conclusion of the hearing, a vote will be taken of affected retired teachers in attendance. If you have not already received your ballot, please see one of the staff members in the lobby area. The respective authorities will then take the matter under advisement, and any vote of the select boards or the regional school committee on this matter will take place at a future meeting. As noted on your agendas, we will now have presentations by a number of folks about this, which will be followed by public comment. During the public comment, if you raise your hand, I will recognize you and a microphone will be brought to you. We ask that you refrain from asking specific questions about coverage or plan design. These questions should be addressed on an individual basis by the health trust manager, benefits coordinators, or with the insurance representatives we have just heard from, or we will have heard from at that moment. Again, thank you very much for coming. This should be very informative, and I now ask Kays Logar to come up and start the presentations.
Hi, and I want to thank you very much for coming out on a beautiful evening. We were thinking it was going to be raining, so it's really nice to see the sun out for a while. Maggie Yeager, who's here someplace, I guess she might be still out in the lobby, is the primary contact for, oh, there you are. You want to stand up so everybody, thought you were Maggie's the primary contact for the retired teachers in their benefits, and she'll continue to assist in this transition if the employers decide to take this route. Teresa Fleur, and I have spoken with many of you, many of your fellow retirees that live out of the area, and I'm happy to report to you that the conversations have been great conversations. We've had a lot of good feedback, and one of the example of one of the feedbacks is the revised frequently asked questions that you might have picked up in the lobby tonight. When we put it together, we used all the plans that are offered to you at the GIC, and we got a lot of feedback that it was confusing because that wasn't what I paid or what people thought that their co-pays were. So because the vast majority of you have the Unicare indemnity plans with CIC, the comprehensive insurance coverage, we revised the charts to reflect just those plans. So if you want to pick one of those up if you haven't already gotten it, that's really the only change that was made to it. I want to make sure that I acknowledge our Insurance Advisory Committee. Patrick Brock is here, and he'll be talking to you a little bit about that, but we have a tremendous collaborative effort working with the IAC in evaluating plans and taking their recommendations after they've met with the insurers and with the employees that they represent. Our IAC is composed of representatives from each employee group. So it's a very broad representation, and Patrick is the retiree representative on the group. So we have retiree representative as well. The other thing that has come about in the conversations is a recognition that we have a little bit different benefits. Some of our benefits are greater, some of them are not quite as good, and so I wanted to bring up that one of the comments has been made about hearing aids, and the GIC provides that benefit. That's something that we're going to be looking into in the future to see what we can do to provide some sort of benefit with that. Another thing that we learned through this was that surviving spouses under the GIC pay what retirees pay, and under our group, they pay 50%. Well, we're going to grandfather all of the surviving spouses so that they're not paying the 50%. It brought up a good opportunity for us to take a look at that as well. And then we'll also be looking at the Medicare Part B premium that you'll be, if you're Medicare eligible, you'll be reimbursed for in the future, and looking at whether or not we need to collect that, your 25% from you before giving it back to you. So those are things that we've noticed and found throughout this. We have folks here from Harvard Pilgrim and from Blue Cross Blue Shield, as well as our insurance consultant, Ken Lombardi from EBS Foreign. They'll all be making some brief presentations for you. I brought a number of my business cards. They're out on the table. If you have questions after this is over and you want to contact us, feel free to pick up a card. It's got my email, phone number, etc. And once again, thanks so much for coming out and hearing the presentation.
Thank you. Mr. Lombardi.
Good evening, everybody. My name is Ken Lombardi, and I work for a firm called EBS Foreign Insurance and Advisory Services. So I just want to make sure that I introduce myself to everybody here and make sure you know what my role is, what our company does. Our firm provides insurance counsel to cities and towns and school districts across Massachusetts. We have quite a few companies, thank you, quite a few municipalities under management. And to be specific about what our role was here in working with the school district and the two towns, and then the Employee Insurance Advisory Committee in regards to management of the Healthcare Trust Fund, it was our firm's recommendation after years of studying the potential that it seems reasonable and appropriate and practical to make this recommendation today to have roughly 300 retirees reacquired from the GIC and put back into the Healthcare Trust Fund. We've been studying it. It does seem practical at this point in time. What this means to most of you is that I can say with complete confidence that your cost-sharing features, what you actually pay for your services when you go for treatment, will be improved. The plans that are offered locally through the Healthcare Trust Fund have lower co-pays, generally speaking, than what you have to pay today. So that's the first thing I want to make sure that we're clear about. I know you've received paperwork on plan comparisons. I don't want to go into that detail. And Pat Kaplan and Paul Lazar from Blue Cross and Harvard will talk about that briefly. I also want to make sure that you're clear that when we analyze this, we look at this in three pieces because your health care plan is really three parts. It's what you're paying for premium, It's what you're paying Medicare for premium if you're Medicare entitled, and then it's what you're paying when you go for services. So you have to consider that those are all considerations when making an analysis on whether or not this was appropriate and reasonable. And finally, before I turn this over to Mr. Brock, because he's going to talk about the collaborative effort with the IAC, the biggest thing that I hope people get out of this is the plan remains local with control. The employees and retirees that are involved in the process are the sounding boards for the membership. We don't have that today under your current insurance arrangement. We follow suit as the GIC makes plan changes and design changes. We don't have any control over that. I see that as a significant feature and a big benefit for moving forward on this recommendation. Hence the reason why our firm has made a formal recommendation to follow this regulation. Thank you.
My name is Patrick Brock. You probably might remember me as a firefighter in my younger days, or as a firefighter union president, used to bargain. And during those times, I was also a member of the IAC, and it was always a struggle many, many years ago to get recommendations moved forward. Times have changed. I'm here as a retiree, having retired. I got back on the IAC and realized through my association, because I also serve as the chairman of the Hampshire County Retirement Board and many other affiliate associations about retirees, the pensions and health insurance are under media attack, and we need to take responsibility on our own. With the changes in collective bargaining, with the elimination of collective bargaining for health insurance benefits, I was very, very pleased to see that the town management turned to the IAC as a sounding board. And we've taken advantage of that. We have representatives from all the unions, we have representatives from the non-union staff, and I serve as the representative of the retirees. And they come with their ideas and their suggestions, and we actually review all the claims, not the individual claims, but the cost of claims on a regular basis. And the town will make suggestions because we now have benchmarks to compete against, and we're watching the GIC very, very close. And over the last couple of years, we've made some significant changes, and all the changes were done with a unanimous support of the IAC. It was done so because if we had objections, if we had concerns, the management people that come to our meetings took them seriously, and we worked together. It wasn't collective bargaining, it was working together for the future. It was a nice way to do things. I guess I lost my old bargaining skills of yelling and screaming and throwing things. But I'm deathly afraid of the attitude in the media and some people about public employees and their benefits. And I think we need to show the way. This idea was first brought to us over 6 months ago, and we wanted to see numbers. And Ken came to us and showed us the numbers, showed us the shortcomings, showed us the benefits. And the committee decided that this could be a win-win for you and for the town of Amherst and the town of Pelham and the school district. And so we voted unanimously to recommend that they move forward with this program and try this. Everyone's going to have individual issues, and we've set up a process where you can get those addressed. What's nice about it is you've raised issues that we weren't aware of and that we're going to continue to work on. I am even becoming more concerned because, like you, I will now qualify. I just got my letter last week. I now qualify for Medicare. So I've become acutely aware of the Medicaid issues. And I'm already acutely aware of the GIC issues because I serve on a couple of state committees. And I'm more fearful of them, but have a greater level of confidence in the leadership in the towns and in the regional school to get you the best deal possible, and that's what the committee's for. The committee representatives are all ages, all backgrounds, all affiliations, and it's surprising how that one person with 3 little kids can make a point and that we can all grab hold of and make sure that our benefits are structured to ensure that it's not a burden on them. I thank you for coming tonight. This is a first step in a long process, and I welcome your questions and everything. and I hope that the IAC can continue to collaborate with management and get the best product for us as former employees. Thank you.
My name is Paul Lazar, and I'm from Harvard Pilgrim Healthcare, and this is Patricia Kaplan.
With Blue Cross and Blue Shield, and we're here tonight to talk a little bit about the plans that are offered to you through the town of Amherst. We're going to start with the senior plans, the plans that are available for folks who are Medicare eligible.
And we're not here as competitors tonight. We're here to inform you of what is in front of you, the decisions you have to make. In the plans you'll find as we go back and forth between each other, operate on a pretty similar pattern. So the Medicare plan that is offered through Harvard Pilgrim is a plan called Medicare Enhance. It's called a WRAP plan, so if you hear that term, and what that means is that Medicare is primary, and then the Harvard Pilgrim benefits wrap around those to cover in sort of the differences in copays. And for one just quick example, there's a deductible in hospital, and Medicare will pay everything but a deductible, and then Harvard Pilgrim and Blue Cross and their plan will pick up that deductible. So that's what we mean by WRAP plan. It's also an indemnity-style plan with Medicare Enhance, meaning that there's no network. You can live anywhere in the United States. As long as a doctor or hospital accepts Medicare, then they will accept the Medicare Enhance plan. So you don't have to look for certain doctors, and most seniors who are in the plans currently under the Medicare plans, obviously their physicians and hospitals do accept Medicare, so it will not be an issue in the transition over to Harvard Pilgrim. You need to have, for either plan, you need to have Medicare's Part A and B, which I'm sure for the majority have, and some newcomers to the field will have shortly.
I can turn that for you.
That's all right. And when you go to a doctor, what you will need to do is show them your Medicare card, and then also show them your Harvard Pilgrim Enhanced card, or the MedX card, and then they will coordinate all of the billing. So they will bill Medicare, and then Medicare will coordinate with Harvard Pilgrim for the rest of the payment. So it's a relatively easy plan from usage.
Two things I'd like to add. Again, the plans are very, very similar. And again, you have coverage anywhere that you live in the country. The MedX plan pays for the deductibles and co-insurance that Medicare doesn't cover. The beauty of these plans is there's no co-payment. You just walk into a physician's office. As long as that physician takes Medicare, you present your Medicare card and your Blue Cross or Harvard Pilgrim card, and that's it. You're done. The billing is all done through Medicare and the carrier that you have. The other thing that I'd like to point out, and I'm sure it's the same with your product, Paul, is that if you're traveling outside of the country, Medicare doesn't cover emergency care, and your MedX plan will cover you for emergency care out of the country.
That is correct with us also.
So that gives you an overview of both plans. And again, they're very, very similar. The plans that are offered to folks who are not Medicare eligible, the town has designed these plans to look very, very similar, whether it's Harvard Pilgrim that you choose or whether it's Blue Cross and Blue Shield. There's two products that are offered, a PPO and an HMO. We're going to talk about the PPO first. So with the Blue Cross plan, it's the Blue Care Elect PPO product. And what that product is again, you can live anywhere in the country. You have a nationwide network of providers. So wherever you live, you will have a network of providers to access to gain the highest level of benefits with the Blue Care Elect PPO. If you find a doctor that isn't contracted with the PPO product, you have the option of seeing that doctor. You do have a deductible and you have co-insurance. And there is an out-of-pocket maximum, but it gives you a lot of flexibility. Again, for those folks that are going to spend 6 months in Florida, or you're going to live outside of the 6 New England states, you have a whole network of providers.
Right. And again, everything that Pat just said is the same. We have an ingenious name that ours is called the Harvard Pilgrim PPO plan, so wasn't a lot of thought put into that. But again, it's a very similar, as Pat just said. There's really no sort of enrollment area. There is a network of doctors that you can receive the in-network benefits for, but we also have physicians throughout the country. So if you end up down in Florida or live in Florida, You can still stay in the plan, and there's also a network of doctors down there that you can also get in-network benefits for.
And I always like to point out to folks, Paul, that with any of the plans, you're covered for emergencies wherever you are. So if you do enroll in a HMO and you're traveling somewhere, you're going to be covered. If you're in a PPO, you don't have to start worrying that you're out of the area and you got to find a network facility. You are covered for emergencies anywhere you go with any of the plans.
And then the third option that we have is the HMO plan. With the HMO plans, it will differ a little bit in that some of our networks are sometimes different, but the match between us and Blue Cross is probably up in the high 90s anyway. But with that plan, you need to live in the enrollment area to join the HMO plan. You need to choose a primary care physician, and you need to get referrals when you see specialists. So that's the major difference between the PPO and the HMO plan. Also with the HMO plan, though, there is no out-of-network. So you do not have that added option of going to a doctor or a hospital who isn't in a network and still receive coverage. So the physician has to be in our network. You need to live in the enrollment area for 9 months out of the year, be eligible for the HMO plan going forward.
And to talk a little bit about the HMO that's offered here through Blue Cross, it's called HMO Blue New England. And what that means is that your service area are the 6 New England states. So that's your service area. That's where you need to live. You need to choose a primary care physician and, again, get referrals for most of your specialty care. As far as our network goes, it's very extensive. Here in Massachusetts, we're contracted with 100% of the hospitals and about 92% of the providers. So you would be hard-pressed to be seeing a doctor out of network. But again, with an HMO, you don't have that out-of-network benefit. Our prescription drug, to just touch base a little bit on that, Blue Cross and Blue Shield uses Express Scripts as our prescription drug vendor. Both, I'm sure the companies offer mail service and retail.
Correct, and we use a company called Walgreen Health as our mail order vendor.
Okay.
And again, once in that plan, emergency, again, you're covered. So if you're in the HMO plan, but you're traveling, you're going to be covered for anything that happens to you that is unforeseen.
Yeah. And with both plans, there's some extra benefits like your Weight Watchers, your fitness, your discount on eyewear, things like that.
So the next time you see us, we'll be battling it out to tell you who's better. But for now, we'll leave that alone.
Thank you very much for your time.
Thank you.
Before the public comment section, the representative from MetLife isn't available this evening, so I'm going to make a few comments about that. I believe some of the retirees have selected the MetLife dental plan that's offered through the GIC. That's a voluntary plan. The trust does have a MetLife plan as well that will be available to you during the open enrollment, assuming this moves forward. The plan is different. It is more expensive. I want to be clear that it's not the same $23 a month or $63 a month that you're paying today. But rest assured, it is, has many more significant benefits. I'm aware today that if you have that MetLife plan through the GIC, when you visit the dentist, certain services, there's a copay that is required by you because not all of the covered services are paid in full. I think cleaning's maybe like $70 or something like that, and you have to pay the balance. The plan that's offered through the trust covers those things entirely, so there's no out-of-pocket cost. And then another example, without getting into too much detail, for instance, the GIC MetLife dental plan, a Crown would reimburse you maybe about $350. But if it's a $1,200 expense, the way the plan works, there's 80% of that cost would be paid by the MetLife plan through the trust fund. So there's a significant increase in benefits. So I would suggest to you that if you're in the MetLife dental plan, this does go through that you may want to seriously consider enrolling in the same dental plan that's offered through the trust fund today. It is more expensive, but I think you'll find it's got significant value. Instead of maybe going through that detail, I'll be available. I have some information if anyone wants to visit me maybe after the big part of this discussion, and we can talk about it offline if that's okay. Okay?
Thank you very much. So at this point, we're going to open it up for public comment because this is about having each of the authority bodies who have to vote on this on your behalf hear your comments. As folks have said, the specific questions about coverage and plan design should really be directed to these individuals either right after this event, or there are also a number of phone numbers and email addresses that have been provided. But, and we don't want you to have to be talking about really your private insurance situations in this big group. But we would like to hear your comments. So at this time, I'll ask you to raise your hand. There will be microphones that will be provided to you from the aisles. I will recognize you, and when you receive the microphone, it will be on. At that time, when you get it, please identify yourself and let us know what you think of this. Sir, in the back. Is there a microphone?
Michael Greenbaum. It's hard, of course, to contemplate change when you've been happy with what you've had for health care. But I appreciate the savings are important. And I have several questions that I think fall into the purview of this meeting. One is, could you comment on the financial health of the trust fund? Because I know several years ago there were some issues about that. And I think we want to be assured about the risk factor for the future. And secondly, why were these plans chosen as the plans available to retirees? And thirdly, is there some information about the history of these plans in terms of increased costs or reduced benefits over a period of time, several years?
Thank you very much for your questions. I'm going to start by asking Mr. Musanti, I think, to comment on the Health Claims Trust Fund. And we appreciate the question because this is, in fact, one of Amherst's great success stories in recent past. And then we'll move on to other folks for the other parts of those questions.
John Musanti, Amherst Town Manager. I appreciate the question. I started as finance director at Amherst in the fall of 2004 and immediately dealt with very serious issues with our health plans. We're what's called a self-funded plan, self-insured. So we don't pay a premium to the insurance company, and we pay our claims. You do your withholdings, and the town and the schools contribute the employer share, and then we pay the claims. And we have to manage the plans and set the rates and all that accordingly. We were in serious trouble 6 or 7 years ago. But as Mr. Brock has alluded to, working collaboratively with all of our bargaining units and with school leadership and our insurance advisory committee, we took a number of changes to retain very rich benefits but modify our plan design and make some adjustments in over a period of years in premium amounts and copay amounts. I know that as of the end of April of this year, and we meet quarterly with our insurance advisory committee, the trust fund balance is a very healthy balance. It actually has over $5 million in it, positive balance, and we actually went negative for about a year back in 2004, early 2005. So we're in much better shape. We're in such good shape, and our claims experience has been very good that we are not making any rate adjustments this July. Last year we had a 3% adjustment. The year prior to that was no rate adjustment. So we think we're in a good trajectory there, and we think we have much better systems in place than 8 or 10 years ago to keep monitoring the trust fund and keep it in a positive direction. We're committed to making the plan work for our actives and our retirees, and I'm going to do my best to do that. Kay can tell a little bit about the history of the plans.
Thanks. The plans were actually Then we've had the same Medicare plans in place for a number of years. The non-Medicare plans are the same plans that active employees have. We switched from what many of you might remember as Master Medical through Blue Cross Blue Shield a number of years ago, and the plan designs we currently have in place were done in collaboration with our consultants, EBS Foreign, and the Insurance Advisory Committee. We spent, I don't know how many meetings, probably over a year in evaluating plans before we made the decisions of which plans to have folks move into. Amherst has had a long history of contributing, well, the group, I shouldn't say just Amherst because it is the town of Pelham, the regional schools, and the town of Amherst. But our group has had a long history of treating the retirees in the same manner as active employees. I don't foresee that changing anytime in the near future. And I think you had a third question that I probably have forgotten by now.
Whether you had evaluated the history of these particular plans, because the information we have gives us a snapshot of what the benefits are and the costs at this moment. But I'm interested to know, as I evaluate the plans, whether the trust has evaluated their history. Have premiums gone up? Have benefits gone down? Can we expect that what this packet gives us will be the case for a few years in the future? What can you tell us about this kind of thing?
I would say that we can expect the benefits at the levels or better to continue. We've made gradual changes to the benefit plans. The last significant one was acceptance of the Affordable Care Act, the Federal Health Insurance Act that was passed in 2010. And that added a lot of preventative care that you're not paying for out of pocket. Before you would have to pay a co-payment, say if you went for a routine physical or something of that nature. All of our plans provide for preventative care. Many of those items are at no cost to you as a subscriber. The history, I do have a history of the rates and how they've progressed over time. And when we look at making any plan changes, for example, when we implemented the Affordable Care Act a couple of years ago, we looked at what it would cost to do that and what we needed to do in order to make that happen. And that was when we went from a $15 copay to a $20 copay. And then, as Mr. Musanti indicated, I review the trust fund information, and the management folks review it on at least a monthly basis. And then we meet routinely with the IAC, present that information to them, what the claims are, have discussion as to whether or not we have to make some changes. So it's a very participatory process that we go through, and I anticipate that to continue. I don't anticipate that we would change it. It's worked very well for the group over the years, and we're very happy with it.
In the blue in the middle. And please identify yourself.
Hello, Carlene Mercelli. I had a question about people who are not Medicare eligible. It seems to me, and I don't know if anybody has taken a look at the people who are not quite Medicare eligible, it seems our premiums are going to be going up approximately $20 a month. I'm not quite sure. Also, you know, that with the dental increases plus limitations that may apply, I was just wondering if anybody had looked at that segment, especially for those of us who retired early because we had health problems. So,
thank you.
We actually did look at that. You're right. The non-Medicare eligible plans are going to, your monthly cost is going to go up about 10% for the health insurance premiums. And, but you also have a deductible that you have to pay before the insurance starts paying. That's $250 for an individual, which just about covers what your monthly premiums are going to go up for the course of the year. I think it's a little left over from that, but that was one of the factors that we did look at in evaluating this. So we believe that even the non-Medicare eligible people will save money when you factor in your out-of-pocket expenses for the copays and the deductibles. We don't have annual deductibles. The only deductible we have is an emergency room copay. And if you choose to go out of the network on the PPO plan, I believe there's a $100 deductible out of network. So it's easy to avoid our deductibles. We don't have the copays for a differentiated copay for specialists. We have no high-tech imaging copays such as the GIC has implemented. So we did take all of the copays into consideration in feeling that the non-Medicare eligible people, which are about a third of the group, would still save money when you combine those premiums and out-of-pocket expenses.
Sir, in the blue, in the middle here.
Yes, my name is Bill Reed. I have a question to kind of follow up on what Mike Greenbaum said. Have there been other towns that have done this, and what have they found? That's number one. Number two is we are increasing our percentage from 15% to 25%. Is that my understanding? That's okay, that's correct. Is there any provision set up for retirees on a fixed income that our percentage is going to remain the same? I know that costs can go up, but at least we'd be guaranteed that the percentage would be 25 and not going up to 30% and pitting us against things that have happened in the past in negotiations where, you know, if you're a good teacher, you suck it up and you do it for the kids. You know, I don't know that, whether we're going to be pitted against programs in the town, and therefore our cost will have to go up. And there was one other one that I can't quite remember right now, but, oh, I know what it was. That's it. We are an expensive group of people. As I watched my friends coming in this evening, we are all limping a little bit more, and we're going to be needing replacements and different things. I know. Sorry, I shouldn't include everyone. You know, we are an expensive group of people, and is the town prepared to deal with that? That's all.
Great questions. Thank you. Would you like to answer?
I'm going to have Ken Lombardi speak to the question of other groups that have done it, and because he's been involved with that. Yes, you might be an expensive group of people, but you're well worth it. You're very much well worth it. The thing that you have to remember is that 2/3 of the group is Medicare eligible, and as was talked about earlier, Medicare pays first, and then either your Medic's plan or your Enhanced 65 plan wraps around what Medicare doesn't pay. So the costs for the Medicare eligible people that the group ends up paying are not as much as you would think they might be, because you are an expensive group, but that's that. Ken can.
I appreciate the comment about the demographics, by the way. I'm glad you said it instead of me. I usually get yelled at for picking on aged folks, if you will. But Kay said something very important. Seniors, excuse me. Yeah. Kay said something very important. One of the big benefits to this decision is, I don't know other way to say it other than we're sending money to the state health care plan, and we don't really see any benefits to it, and we don't have any control over what benefits you get when you're there with the state plan. The state decides changes in copays, possibly changes in contributions. We don't know that. I mean, they've done that before in other plans, so that's out of our control. As I said earlier, I don't think I want to overstate that again. That's a big, big factor in this recommendation. Let me back up 1 minute. The non-Medicare retiree question. Just please keep in mind, when you go through open enrollment, if we get to that point, you have multiple plan options. Kay is right. If you choose to stay in the same model plan you're in today, the indemnity or PPO style plan, you'll see a slight premium cost increase. Yet, if you decide to look at the other options, either Harvard Pilgrim or Blue Cross's HMO, you could save as much as $800 in premium a year with better benefits. So I would please urge you to not just simply look at what you have and say, okay, I'm going to be in the same plan design I had currently. Take the time to evaluate your options. If your physicians are all in these network plans, why wouldn't you make the recommendation? You turn to those physicians for specialist care and referrals. Why wouldn't you make that recommendation? You'll save premium and you'll improve your benefits. So I don't want you to just simply think that this change is going to cost you more in premium. It may not do that. Other towns have gone through this process. They've done the same thing that you folks are doing today. I've yet to see or hear the repercussions. I've done it in several towns, most recently the town of Franklin, which is about the same size as this organization. We don't have any real issues because they moved to, excuse me, Paul, the Blue Cross Blue Shield Medics plan, which quite frankly is, along with Harvard Pilgrim Healthcare Enhanced, will be the most robust level of benefits you'll ever find in a healthcare plan, bar none. All right, I can say that because I've been doing this so long, getting yelled at by members, that I don't hear the noise after these decisions are made. Now, I know you're not going to take my word, I'm just an advisor, but trust me, these plans will outperform where you are today. That's the reason why I was comfortable making a recommendation, getting grilled by the appropriate boards about this decision. So I'm very comfortable that this will work out in your favor. Another thing that I just want to make sure, Mr. Musanti talked about, the diligence and the financial oversight is extremely effective here at Amherst, Pelham, and the school district, and it's really not typical to other communities who really haven't focused on that. The assets, the money that you sent to the state should go into this trust fund because it's measurable, and as Kay had said, 80% of your claims are paid by the government if you're Medicare entitled. So we know what that 20% is worth. So it's valuable to be able to know that and predict it and have that revenue come into our own back pockets. So there's a lot of reasons why this makes sense, whether it's from a consumer perspective or whether it's from the healthcare trust fund. But one other point, again, I get back to it. Please keep in mind you have multiple plan options. The GIC restricts you to the Unicare options, Fallon Senior Health New England, maybe one or two others if you're Medicare entitled. And then if you're not Medicare entitled, only another handful of options. Some of those are very expensive. Our premium rates, as John had said, they've been very level over the last couple of years. Yet I've seen the most popular plans in the GIC, which is not necessarily the Tufts Navigator that we hear about, it's the Unicare Indemnity Plan, has had a number of rate increases over the last several years, almost 10% in 2 years. Okay, so I'm concerned about that because while I don't manage the GIC contributions today, that does affect my clients' costs because that's money that they don't have to fund local expenses here. So it doesn't directly cause me to be concerned. Another reason why I think this makes a heck of a lot of sense. All right, so again, my point was please make sure you look at those plan options. I think you'll find some cost savings even if you're not Medicare entitled. Yeah, in the Part B, yes.
Just very briefly, I wanted to address concern you expressed about premium contribution and what could happen. In the town, for this health trust group and in the town of Amherst, we have a long history and I think successful history of treating In terms of contribution rates, actives and retirees the same, even though state law allows us to go all the way as low as, or as high, from your perspective, as 50% contribution. We have a history of not treating the retirees different. And so I think that has worked well for us. I see no reason for us to change course. And we talk about that with our insurance advisory committee regularly. Also keeping in mind that treating all of our retirees equitably, including the non-teacher retirees. You know, this trust fund offers a Part B reimbursement, Medicare Part B reimbursement of 75%. That would apply to you as well, so that you're being treated the same as the other retirees in our system.
Thank you, and I'll note that those other retirees are also an expensive group, so the town does have experience with that. Ma'am in the middle here.
I'm Jan Salisbury. I had actually a follow-up question about the plan information we received, and then another question about the reimbursement that you just talked about. About the plans, when you said it was a wrap plan and that it would be similar to the indemnity plan we receive now, so that we could receive, we could go to any doctor anywhere that accepts Medicare. What about if you end up at a doctor that does not accept Medicare? How does the plan then reimburse or cover, or is there any coverage for non-Medicare for either of those two plans? That was my first question. Number two, I think people kept saying out of the country if you're, out of the state if you're in Florida or if you're out of the 6 New England states, but I'm not sure that I heard out of the country. And I'm wondering if that was addressed also. And my other question is about the reimbursement that you just mentioned. I know that it says reimbursement, but I don't think we really have details in our information about how that reimbursement would take place. Because right now, it feels like if my plan is going up $40 a month, even though my benefits might be better that I might use, but I might not use, and my dental is going up, then I'm going to be paying there's going to be quite a bit more being taken out of my check every month. So I'm wondering about what the reimbursement plan is and when that we would see that reimbursement and under what conditions. Is it taxable? Is that reimbursement taxable money? So those are some questions that I don't think we received information about.
We're going to do this together again. Both of us have the same understanding with the Medicare wrap plans, is that if you choose to see a doctor that does not accept Medicare assignment, what that means is that you may be filing your own claim and that you can be balance billed. Most doctors do accept Medicare. I think you find a rare instance maybe in the Carolinas or a few in Florida, but up here in the Northeast, you'll find most of the doctors do accept Medicare.
Right. It's really not encouraged to see a doctor under the enhanced plan or the Medicare plan that does not accept Medicare. Because of the fact that it could get expensive, they don't really have to follow the rules. And in reality, most of those doctors will probably refuse to see you. If you're in the indemnity or the Unico plan, the Medicare plan, the OME plan that they have, then chances are, and there's a very strong chance that those doctors already do accept Medicare. So that's probably not going to be an issue.
Good. Out of country, emergencies are covered out of the country with either one of our senior, well, with any of our plans, but our senior plans, Medicare specifically does not cover emergency care outside of the country. Both our plans will cover that care.
Right. There is a chance that you'd have to pay for it, obviously, and then get reimbursed once you come in here. But it still would be a covered benefit.
No, it's covered at
No,
100%
it would be
under
covered, despite if there's any co-pays or things that are detailed in the plan would come off of that. But.
Okay. The Medicare Part B is a reimbursement. It is paid in June and December of each year. So you would receive a check from the trust fund or from your employer. I'm not exactly sure how they're doing that, but the checks get mailed out. They were mailed out last week for the first 6 months of the year. It is not taxable. It's a reimbursement. We don't send you a 1099 because you got a reimbursement check. You are going to continue to pay your Medicare Part B premium however you're paying it now. Some of you are paying it monthly through a Social Security deduction. Some of you are paying it quarterly via a bill. That will continue to happen. The difference is that we're going to reimburse, the group would reimburse you for what you're paying out. We're going to be looking at the fact at whether we actually have to collect the 25% premium from you for the Medicare Part B, or if we can just reimburse you the 75% without having collected the premium from you. But that will be down the road, and we should have some answers to that probably before you would be signing up.
Other folks over here in the back in the dark blue.
My name's Dale Carew, and I want to talk about something that Bill brought up. The last time the trust fund got in trouble, I can remember that, and the rumor was that it was just a few people with fairly complex illnesses that brought the plan down. And I'd like to know what the truth is about how the plan got in trouble.
Thank you.
It wasn't just a few people. Starting in 2003, we had a number of very large claims that amounted to well over $1 million at the time. We did not have reinsurance at that point in time, and we were on the more costly master medical plan. So that's what that crisis, if you will, is what prompted the IAC and the towns and school district to look at implementing the present plans that we have in place today. We also have reinsurance so that if we have a catastrophic claim or a number of catastrophic claims, we are reimbursed for those claims over a certain dollar amount. So those safeguards are in place now. They weren't in place then, and like I said, there were a number of very large claims. So I think that we've taken measures not only to change plan design, which has worked out very well for our subscribers, but to take care of those catastrophic claims that might come up.
I remember the audible gasp in this auditorium when the two town managers ago, Barry Del Castillo, talked about our health claims trust fund trend and showed the 2004 experience. I know back because while there were a handful of large claims, they didn't trigger the trend. It was the general trend in the healthcare cost inflation during that period of the mid-2000s that was double digits. That coupled with inadequate premium adjustments at the time caused the trust fund to be depleted. One of the things we did in analyzing what happened was try to answer that very question. And that was the issue of if we had had reinsurance, which is catastrophic cost insurance. So we're self-insured for all the claims, but then we have a smaller insurance policy that we purchase now for claims over a certain amount, individual claims over a certain amount, so that there's not any one claim or handful of claims that can bankrupt the trust fund. So that did not occur. It was just general trend of cost at the time. Now that the trust fund is healthier and we have those controls in place, and when we do have an individual claim that goes over the dollar threshold, we are being reimbursed. We all pay for that through the trust fund, but it's protection, additional protection in the trust fund, so we don't have that issue.
Over here in the striped shirt, right in front of the woman before.
I'm Amy Walpin. My question has to do with support for transitions back, for the change. Because I've had a ton of problems with GIC. In fact, it was a good thing I was retired because I was on the phone with them almost every day in the fall. And even this week, I still had problems getting a prescription refilled, which they refused. So we had to fight that. We've had vendors cancel medical equipment, etc. So in switching back, what kinds of support can, maybe it's the healthcare plans themselves can speak to this, can we be provided with for troubleshooting the transition issues? Because I anticipate that I would run into them again.
Thank you.
Thank you, Paul. Well, a couple of ways that you can do it with Blue Cross and Blue Shield. First of all, once you get your ID card, you will have that dedicated 800 number for member services. And I truly can't stress enough how good our member services department is. They will pick up the phone if you have a bill. They will call your provider. If you're having trouble picking up a non-formulary prescription, or it's just the transition's not working for you, if you have medical needs that are causing this transition to be difficult, they'll get case management involved. And ultimately, you always have your human resources department here. Maggie has my direct line. She always knows when I'm calling. So certainly on the sales end, we would get involved with any transitions.
Yeah. The situation you discussed, I handle the Group Insurance Commission for Harvard Pilgrim also. And the situation you discussed about especially the prescriptions and all that is not uncommon, let's just say, in that area. But with the Harvard Pilgrim plan, just to talk about the prescription briefly, any drug that is FDA approved is available through Harvard Pilgrim. Again, we have member services department that will be set up. If this goes forward, we can also try to set up a clinical transition program, so people who are in the middle of procedures can talk to one of our nurse case managers, and I'm sure the Blues has something very similar to sort of walk you through the September 30th to October 1st sort of transitional deadline. But again, both plans have been ranked in tops in the country for numerous years, and one of the main reasons for that is due to the customer service and the member service side of the plans, which, quite frankly, Unicare cannot compete on the same level with that.
And while we're up here at the podium, I would just like to take a minute to talk about referrals. So a lot of you folks haven't ever experienced referrals. You're either in the Unicare plan, or when you're here with the trust, you're with Master Medical. The referral system's a lot different than it was 20 years ago. And we all remember the days when you needed to get a referral from your primary care physician, you had to run down to your primary care physician's office and you had to grab the piece of paper, and it doesn't work like that anymore. Referrals are all done electronically now. They can be done for up to a year. If you get to a specialist, you forgot your referral, it ran out, whatever, you can call your primary care physician. They can get it into the system electronically. It's a lot different than it was 20 years ago. And I'm sure the same for Harvard Pilgrim. Thank you.
I'll look to other folks, just so you know, we're not leaving here till all your questions and comments are answered, so don't worry if I haven't called on you yet. I just want to try and look around and get different parts of the room. Okay, man with the red hair here in the middle.
My question is, if there is no change, what is your prediction? What do you see if we make no change?
Okay, could you identify yourself, please?
Oh, I'm sorry, Jane Price.
Thank you. If there's no change, what's the prediction? Is that correct? That was the question? Okay.
If there's no change, I don't think we have a prediction. We can't control what the GIC does. So if the employers did not vote to transition you folks to the Amherst Pelham Claims Trust Fund, you would remain with the GIC, and you'd be subject to whatever premiums were charged and whatever copays were charged. So we wouldn't have any way of controlling that or knowing what it was going to be.
In the back on this side. And please identify yourself. It's not working. 1 second.
Maggie, do you want to bring the other one over? Maggie, do you want to bring the other one over? Just kidding, Mary. Okay. Mary Malonis was from Marks Meadow. I'm one of the people that's non-Medicare, and in the past, I'll reference GIC, like last year, there was no increase for anyone in the Social Security system, so there was no increase in their Medicare rates. GIC put that increase on those of us in non-Medicare. In any of these plans, is there any differentiation on increases from one plan, from non-Medicare to Medicare? That's one of my first questions. And the second is that someone, I'm not sure who it was, mentioned a $250 deductible. And I think she was talking, I think it was you, for both plans. And there's nowhere in any of this that it talks anything about that. We pay that for GIC in my non-Medicare. But there seems to be a few little things missing here.
Thank you.
Our plans don't have a deductible on them. The GIC plan, the non-Medicare plan, has a $250 deductible before the plan begins paying on most services that you would have a copay on. As far as the premium increases, we do two different things. Almost every year, the increase is the same across the board for all the plans. So the last increase, we had a 3% increase. The Medicare plan saw a 3% increase. The PPO plan saw a 3% increase, and the HMO plan saw a 3% increase. We do look at our claims by the groups. So we look at our Medicare plan claims. We also look at our PPO claims and our HMO claims. And there will be a time, in all likelihood, where we'll be looking for those groups to support their own claims, so to speak. You can't do it with catastrophic claims, obviously, but we will, that is something that we closely monitor. But in recent memory, I don't recall us having anything but an across-the-board increase for all of the plans.
The very back corner there.
Regina Gulliver.
And I have a good, strong voice. I just wanted to say that as someone, I'm going to be this person for a minute, but as somebody with a dependent with substantial needs, I am very disappointed in GIC
welcome this change that's suggested tonight. They have been, at best, unresponsive, dismissive, and arrogant, and I can't wait to get rid of them, so I hope everyone thinks about what it's like not to have good health.
Thank you. Could you just state your name again for those of us? Gina Gulliver. Thank you very much. Okay, there is someone down here in the pink.
You had mentioned that the referral process was very simple. As a member of GIC, I have never needed a referral. I've been free to go to a specialist without any process like that. Would this be true under the trust, or will we always need referrals? Oh, Kathy McKay, Marks Meadow.
Okay. Under the PPO plans and under the Medicare plans, you do not need referrals. I can say that you do have to have referrals under the HMO plans. So if you're non-Medicare eligible, you would have that option. As Ms. Kaplan said, it is extremely easy under the HMO plans. I'm an HMO member, and I have never once had a problem even asking for a referral, because generally when you go to a specialist like I do, they've already called your primary care to get that referral, and it's been transmitted electronically, so it's seamless to you.
Looking around for different folks here. Okay, then we'll go back to seconds. Sir, right here.
Yes, this will be my last time. I promise. Okay, Bill Reed again. The question I have is, we do not have a GIC representative here tonight. You've done research. I'm sure, on what GIC offers us. What are we giving up? What would a GIC rep say? I mean, what are we giving up if we go to the town?
The only thing that we're currently aware of that you're giving up is a hearing aid benefit that I alluded to earlier, that the GIC presently pays up to $1,700 every 2 years for hearing aids. That is something that we are going to be looking at to see if that's feasible to offer. But that's the only real benefit that I'm aware of that you would not have under our current structure.
Oh, it is on. Just to sort of get my mind straight, and maybe some other people's, about what this all means. As I just got onto Medicare. So as a Medicare participant, I look through the book, and Harvard Pilgrim is one of my choices, and it says my eligibility is retirees, GIC retired municipal teachers. So I'm seeing that I already have Harvard Pilgrim as one of my choices as of rates effective July 2012. What's the difference between the Harvard Pilgrim I would choose here and the Harvard Pilgrim that you're saying we're getting through the town? Is it that GIC is managing this Harvard Pilgrim? And whose decision is it that the premiums are going up? Harvard Pilgrim's decisions or the trust's decisions? I'm a little confused about when you're talking about we and the premiums and who's controlling the premiums. And if I'm choosing Harvard Pilgrim, who's deciding whether the premiums are going up and by how much they're going up? Is it the trust or is it Harvard Pilgrim?
Come on, Paul. I'm going to let Paul talk about the Harvard Pilgrim. It is the trust that decides what the premiums are going to be for each of the plans that are offered.
The enhanced plan that is offered through the GIC is a fully insured plan. So there is a little difference between that that's a funding difference between that and what is offered here through the trust, which is self-insured, as was mentioned earlier, which means that, we sort of give Ken and the trust all the claims information, and they sort of develop their own sort of working rate or premium equivalent. There are some differences in benefits between the GIC Enhanced Plan and the Harvard Pilgrim Enhanced Plan. Hearing aids, again, being one that is a sort of the major difference. But both plans are run and operated by Harvard Pilgrim themselves. So from that standpoint, there is no difference as far as that goes.
In the green in the back corner.
Hi. Is this working? Brian McNamara. I have a question about the Medicare Part B reimbursement. Some of us in the room, because of military service or work in other jobs besides teaching here in Amherst, qualify for a meager amount of Social Security. Meager being because of that no double dipping part. My understanding is that if we apply for Social Security, they use our Social Security to pay the Medicare premium. How does that impact your willingness to reimburse us?
We don't care how you pay your Medicare Part B premium, we're still going to reimburse you. So it doesn't matter if it's deducted from a Social Security check or if you're paying a quarterly bill. You're still going to receive the reimbursement for Medicare Part B.
Over here in the white. Light blue, sorry.
Casey Schmidt. Like Regina, we have a multiply handicapped adult son who lives with us, and the GIC was difficult to deal with in that regard, to the point where we ended up just keeping Brendan on Mass Health, partly because the family plan was way more expensive. The other thing is my husband is on the Medicare plan, I'm not, because I'm so much younger than he is. I can say that because he's not here. And right around this time last year when I retired, I had Maggie on speed dial, much to her chagrin. So, yeah, this will be on TV, won't it? Oh. So I better make sure he's not watching that night. So what happened with us was he gets the individual plan for the Medicare. I got the individual plan for the non-Medicare on the GIC. And then we didn't do the family plan because it was so much more expensive. So my question is, if we go back to Harvard Pilgrim or Blue Cross, is it just an individual plan for one person and then a family plan for everyone else? Or do we do it the way we did there, where we do actually 3 separate plans or 2 separate plans? Do you understand what I mean? It was complicated.
It is complicated, and one of the things that we're looking into is that situation, because we do have more than just you that have people that are dependents that are staying on the plan and have an entitlement to stay on the plan. But when Medicare comes into play, it also oftentimes comes into play for those dependents as well. So that is something that we're looking at, how we can best do that. Because obviously it's to the plan's benefit if we have the Medicare people in the Medicare plans where they belong. So we are aware of that, and we will be trying to work with you on that.
Up front here in the tan. Up front, I'm sorry.
I'm Frances Caparello. If, in fact, this change does go through, will we have another opportunity to meet with representatives of Harvard Pilgrim and Blue Cross to get our specific individual questions answered in more detail so that we can make an informed choice between the two plans?
Most definitely. They will be available for consultation by phone if you prefer that. We will, in all likelihood, also have an open enrollment session where all the vendors are invited to come, and you can come. I know that doesn't work for people that live outside the area, but Blue Cross and Harvard Pilgrim and MetLife have all been very willing in the past to meet with people, to talk with their customer service people, and they know what we have for plans because, you know, it's all computer generated, and you can talk with them much more freely about your individual situation and what your needs are.
Ma'am, in the back, in the middle there.
Elisa Rubenstein. I have a question about GIC fully insured, trust self-insured. So I'm looking at the long term, 5-10 years out. What does that mean as far as the protection that we have that our health plan will not run into problems?
Let me start, and I'm sure John will stand up and fill in all the empty spaces. Because we had the problem in 2003 and 4, I think everyone involved in this is more acutely aware of that we're managing a benefit for you, and that we really look at every plan. Coming from the retirement side, this is a negative in a way. Retirement benefits are guaranteed under law. Health insurance benefits are not. And as the media attacks us, unfortunately the legislature tries to respond. And right now, as part of Pension Reform 3 that was passed in December, they've set up a special committee to look at health insurance specifically. I hope you're all members of the Mass Retirees, because it's one of the strongest lobbying groups to protect your benefits. Ralph White and his people there are great, and I deal with them on a regular basis. But what we're looking at is we've working constantly at the state level to convince the legislators, and Ralph does an excellent job on this, to protect the retirees. I can assure you that the discussions over the last few years has been to look at health insurance benefits paid to early retirees, paid to people who did not go out at 80%, that if they're not at full retirement, they shouldn't be getting a full health. But it's all prospective. It's all going into the future. The things that we talk about on the committee that we watch the legislature very carefully, and one of the things that has brought us to light is the new Gatsby rulings where you have to report the unfunded liability of your retiree health benefit. And this is where the retirement system, both in Hampshire County and in the state, are looking at methods to help local communities start building their OPEB funding. The town passed the town meeting to set up an OPEB fund. The state has stepped up and worked very hard to get special legislation to allow the state PRIT fund, which is your state retirement fund, to actually manage the money in a professional way to get a higher return. The media's grabbed this because if you don't have a fund, you have to almost use the risk-free rate to determine the level of cost for benefits in the future. If we can get and start the funding, we can lower that rate to an investment rate, which will lower the unfunded liability. I know this is all numbers and strange to everybody, but we who work on it every day are trying to find a long-term solution. From the retirement side, if my retirement board continues to work hard and we set up a funding schedule for the retirement that has a declining rate of salaries, then if a town is used to spending 19% on retirement deduction, as our rate goes down each year, we're trying to convince them to step up and take the balance. If we go down to 18%, then take 1% of salaries and start putting it in the OPEB trust fund. You know, you're probably a group that has the worst unfunded liability in the state, and this is one of the attacks. I'm very pleased that the town manager, the finance director have all worked with the state, gotten information, and hopefully we can move forward on this. Bottom line, it all comes down to the economy. But rest assured, the debates among the committee are very surprising because the committee members want the fairest rates possible. Not the lowest rates, but the rates that will sustain the fund. And I think everyone on the Insurance Advisory Committee is very committed to that.
Ma'am, here in the black.
Carol Schweid. I appreciate all of you coming here tonight to give us this information. It's helpful. And I felt very uncomfortable at first when I looked at the material that was sent to me because I felt there were so many things that were missing. And while I still don't have a good, clear picture of what is actually offered, if I'm hearing everyone right, what I think I'm hearing is that one of the main reasons for making this kind of shift is that it'll give much more local control to premiums and growth and the building of a trust that is equitable, as opposed to staying with GIC and leaving it in the hands of an outsider, in a sense. But Pat alluded to the role of the legislature. And I guess what I'm wondering is how protected, what can we do to really protect ourselves from that onslaught? I mean, this certainly seems like a good step, but is there anything else, and will we have more opportunities for input like we're having now?
Back in 2004. But it is important. We're making the decisions locally. Retirees have a voice at the table through the Insurance Advisory Committee. And it's not a, meet once a year and rubber stamp something. We're meeting with them quarterly. There's an agenda. They're getting financials on the health of our health trust fund quarterly. And we're trying to make decisions and raise our collective understanding of health care and health insurance issues as we go along. We operate local government and public schools in the Prop 2.5 era in this state, so our revenues are capped in a given year, our biggest revenue. It is incumbent upon us to manage our employee benefits and our health care costs well. It's critical. We have saved millions of dollars through plan design changes while still offering two of the top-rated health plans in the country, Blue Cross and Harvard. And so we're committed to this. We have to be to provide really good, solid health care benefits, but also preserve our public schools, public services, public safety each year.
Quiet side of the room over there. Okay. Over here.
Paul Carlson.
Oh, thank you.
If the decision is made to go back to the trust fund, does this preclude, should fortunes change, ever moving back into GIC? That's one question. The second is a comment Kay made earlier about surviving spouse. Could you just clarify what the current employee cost is under GIC for surviving spouse and what your comments were initially about the 50% and 25%?
The thing with surviving spouses, currently under the GIC, they either pay 10 or 15% of the premium. Under our group, the surviving spouse pays 50% of the premium. That would be very harsh for few surviving spouses that are currently on the GIC to move back into our group. So what we're doing is we're treating them just as though they were a retiree, and they will be paying the 25% just as all retirees would pay. In terms of making a decision to go back into the GIC, I believe, if I remember correctly, Ken can probably correct me, there's at least a 3-year window, so we could not vote to re-accept the law for at least 3 years.
Here in the back in the pink.
Kathy McKay, one last time. 2 questions. I've not heard one word about prescription costs, whether they might be expected to remain about the same. The other one is I'd like to know a little bit about the timeline if we vote to go with the trust, particularly since you aren't going to deal with hearing aids for a while. Perhaps those of us who have difficulty hearing need to run out and get new hearing aids immediately.
The timeline is that if the employers vote to accept it, they have to give the GIC a 3-month notice. So the very first opportunity for enrollment in the trust group would be October 1st. And that is what they're contemplating at this point in time. If the employers vote to do this and rescind the chapter of the law, then we will have an open enrollment. You will get a mailing in mid-July and probably have at least a month to make your decisions. It'll be much more informative than the information that was sent out with the notice of the hearing, and we'll have people available for you to talk to on an ongoing basis. Maggie is available. Teresa Florent, who couldn't be here tonight, and myself are always available. You've got our emails and phone numbers. My card is on the table if you want to take that as you leave. We're more than happy to talk with you and answer questions or put you in contact with the people that can answer the questions. Oh, prescription drugs. The prescription drug plans, under the Medicare plans, Blue Cross Blue Shield has a 0 copay. Oh, thanks. Let's see if I remember this. They have 0 copay for a 30-day generic supply and a 20% copay for a 30-day brand name supply. And if you use the mail order service through Blue Cross Blue Shield, which you can do for all of your maintenance drugs, it's a $2 copay for generic supply and a $15 copay for brand name. Harvard Pilgrim on the Medicare plans and the PPO plans and the HMO plans, I'm sorry, let me back up. Harvard Pilgrim on the Medicare plans has a $5 copay for generic, $10 for preferred brand, and $25 for non-preferred brand prescription drugs. And on the PPO plans and the HMO plans, it doesn't matter which provider you have. It's 10, 25, and 45 for a 30-day supply or a 90-day supply through the mail order plan. Non-Medicare eligible, under 65 members can also use the Canarex plan, which is no cost for your brand name prescription drugs if it's a drug that Canarex provides. Those do have to be mail order and they do have to be 90-day supplies, so you have to work with that. Thanks, Paul.
Yes, ma'am, in the green and blue back.
Good evening, Rita Romano, class of 2006, 2007. Yay. My comments are directed towards out-of-system services. I live in an area that there's a significant number of physicians and an increasing number who do not accept any insurance at all, and an increasing number of physicians and services that do not accept Medicare, which already limits the physician pool. And I assume that I will have to use the MedX or Medicare Enhance. And I'm concerned about the quality of care protocols. When Glick changed our PPO and we went to their physician list and called to make appointments, we were told that they no longer accepted that PPO. So what quality control protocols do you have in place that will ensure that if there are physicians that are on your eligibility list or are not accepting patients, do you have any resources? And do you have any assessments or report cards about the quality of care of the physicians that are on your list?
Thanks, folks. Do you want to speak? Where do you live, ma'am? Okay.
This is not a common question that comes up here in this area, so you must be experiencing some differences in Washington. What I can tell you is that if you are on the PPO and your physician does not accept the insurance, then you could see that physician on an out-of-network basis and be responsible for a deductible and co-insurance. Which PPO is this? Is it? And yeah, but I guess what I can do is I can address certainly the provider.
That periodically check to make sure that it's an active list, so that, I mean, a lot of people spend a lot of time trying to find quality physicians who also match your eligibility list. And when you find one that's on both of them and then you call and you don't go through, and then how can we screen through physician services and other services, because there don't appear to be any kind of report cards or anecdotal notes that give us a sense of the quality of care that's being provided.
For Blue Cross and Blue Shield, we update our provider directory online almost on a weekly basis. So your networks, when you're looking online, are going to be accurate. We also have quality care tools at our website where you can see where physician rates in cost and quality.
Right, and I would say the Harvard is very similar to that. If you go to the websites, is the fastest way to find out doctors even out of the area if they're part of our network that is out of the area that where you can get the in-network benefits. But as Pat said, you're never going to be without coverage under the PPO plan due to the fact of there's a deductible and it's an indemnity style plan and an 80-20 coverage. Now, are you Medicare eligible?
No.
No.
And I also want to say with Blue Cross and Blue Shield, we're part of a national Blue Cross and Blue Shield association. So you have an extensive network in every state through Blue Cross and Blue Shield.
And we actually partner with an outside firm to sort of rent their network. So again, it's every state is also doctors covered.
I would certainly encourage you to just hop on the website. You don't need to be a member. You can go in as a visitor, go under Find a Doctor, and just kind of peruse the website and see what you come up with for those types of tools and lists.
I'm going to try something different first and say, if folks' questions are more specifically about how they're going to decide to change, but they're more in favor of this, then maybe we could hold those questions till the end, or maybe you could deal with these individual folks afterwards about that, if your questions are about how you're going to decide which plans to choose. But if your questions are about really trying to decide how you're going to vote, whether you'd prefer to stay with the GIC or make this switch, then we'll try and look at those questions right now. So I'm just going to put that out there and see how we do. Ma'am in the back in the blue sweater.
Hi, Kathy Neal. I just would like to know the difference between GIC and the two plans you're offering now. Let's say you have a spouse who has their own individual insurance and then their company decides to take that away from retirees. Is that a qualifying event, and will you allow, will any of the plans allow your spouse then to be on a family plan with you?
If you have an individual plan and your spouse loses coverage, not just decides to cancel coverage, the loss of coverage is in fact a qualifying event, and you could choose any of the plans that you would be eligible for, whether it be Medicare or non-Medicare. I have to say that we're under the state mandate of last July that we have to enroll all Medicare eligible people in a Medicare plan, just as the GIC presently does. That's new for our group. It went into effect for us last July, but we do have to do that. So if your spouse is Medicare eligible and loses coverage through his employer, then he would be entitled to join yours as a qualifying event. If he's not Medicare eligible and you are, or vice versa, it's still the same thing. It's still a qualifying event.
Ma'am here in the middle, in the brown.
My name is Naima Mohammed. I'm interested in finding out a little bit more about the temporary exception of the Medicare eligible enrollee that has dependent children. How does that work with Medicare?
If you're Medicare eligible but you have dependent children, you stay on the family plan. Unless it's a situation where that dependent is going to permanently be on your plan because of a disability of some sort. And then once the dependent eligibility no longer exists, then you go on either the Medicare plan or the non-Medicare plan, whichever you're eligible for.
Since some folks are starting to leave, I just want to remind folks to make sure that you vote if you're ready to vote tonight before you leave. So anybody who is leaving at this point should make sure they get their ballot and hand that in if they're interested. In the back, in the light blue. Hold on just 1 second for a mic, please. We need a mic so we can hear you, and on television they can hear you as well. It probably will work. Just speak into it. There you go.
All right, I guess it's on. Ann Matheson. This is going to be a very simple question, but the older I get, the more I appreciate simple things. Now, will there be a gap in coverage between, if the vote goes to go to these new plans, between the ending of the old plan and the beginning of the new plan? Will there be a gap that needs to be covered?
No, there will not be a gap. Your coverage will end at 12:01 on October 1st with the GIC, and it will start at 12 midnight with whatever plan you choose to accept. And I can tell you from personal experience that if you're in the middle of some sort of medical situation, for example, I was hospitalized on October 29th, and we changed insurance on November 1st 1 year, and they coordinate the benefits so that you actually have both insurers, the ending one and the beginning one, taking care of your care or your situation. I also want to, that also brings up the fact there are no waiting periods for any pre-existing conditions. If you have something going on medically that you're treating for now, you're going to be treating for it as soon as the new insurance kicks in as well.
Ma'am, here in the front.
Annette Fannebecker. I was just curious about the survival spouse benefit that people will be grandfathered in, but from GIC. But then, if we all go to the trust, and there is a surviving spouse, and they would pay their insurance. Would they go up to 50% of the payment?
Actually, this situation has provided an opportunity to look at that, and so we will be looking at that for all retirees, because one of the primary bases for our plan has been equity between all groups. So we'll also be looking at changing that rule. I can't guarantee that it'll change, but we for sure will grandfather those people that are currently surviving spouses, and we are going to be examining changing the rule.
Another issue, getting tired, but GIC has a good vision benefit. I don't know what the benefits of these plans are for vision. I think they're probably a discount benefit. Is that right?
Well, the routine eye exams are covered at copay.
And no, eyewear.
We have a discount.
It's
Okay.
a discount. Yeah, GIC has a really good plan that, you know, if the plan switches, you might want to look into it as the trust goes to look at if it's cost effective for Amherst.
Yeah, the insurers do have the eye exams covered, and there are some discounts for eyewear at the present time. But that is also something that we can look at, and also through the MetLife Dental, there's some discounts with Davis Vision, I believe it is. So, and those are open to everyone, regardless of whether or not they have the dental insurance.
Other questions or comments?
I just have one last comment.
You still have to wait for the mic.
I'm Jan Salisbury. I just have one comment about the voting. I'm sitting here looking at this, and I know that this is not a time to ask about our own individual specific benefits, but it's kind of hard to make a decision on principle when, we have such individual benefits that we don't know. The eyewear, the hearing aids, we have such individual cases that it's really hard to make a decision on principle when we don't have that information. So I feel like I can't really say yes or no because I don't really know enough yet.
Okay, that's an important comment, and I appreciate that. So we're going to have to see how this vote goes. This vote is advisory to these various bodies. If the determination at the end of this evening is that folks don't have enough information to make an advisory vote to us, then we'll have to act accordingly, but I appreciate the comment. Sir, over here.
Hi, Sandy McNiven, Fort River School. Just a quick question on that $5 million. Whose mattress is it under? Or which hedge fund have you got it in?
It's under the town treasurer's mattress, invested in our town investment accounts separately. The town treasurer manages the finances of the trust.
Other folks, and again, if you have more general comments that you think that this whole body should know, as well as the authorities up here who will be voting, that you are generally in favor or not in favor of this, that would be also valuable. Okay, ma'am, right here. The mic is coming.
My name is Betty Turner. One of the things that I'd like to know, which would help me to vote, is what is the likelihood that we could remain with our present primary physicians, or in my case, it's a group. So.
If you reside in Massachusetts, Blue Cross, our network in Massachusetts is extensive, 100% of the hospitals, about 92% of the providers. And again, I would encourage you to go online and take a look to see if your provider is part of either the HMO or the PPO.
Well, it's not like a broken record, but the same. The network of doctors, it's a minuscule number who is not actually enrolled in one of our plans.
Ma'am, over here, in the blue. Just one moment for the mic, please. Thank you.
So my PE teacher's voice isn't going to cut it without the microphone. That's why it sounds like this, actually. I'd just like to make a comment that, especially having an adult son who lives with us who's disabled, I have not found, like Regina, she's gone, but I have not found the GIC, the Unicare part of it, to be very receptive. I've also found I'm very healthy, but I feel like I've been putting out money for co-pays for every single thing. And you know, I just retired last June. We were on Harvard Pilgrim. I never had an issue ever. I always was able to talk to somebody right away. Anytime we had issues with Brendan, there was somebody there. People were very receptive. I have been actually very disappointed in the Unicare part of the GIC. So for me, I actually am kind of excited about the idea of going back to a smaller entity, not such a big, huge corporation where you really couldn't get people on the phone that knew you or knew anything about your cases. And I felt like I got the runaround quite a bit. So for my part—
Excuse me, folks over here, you need to be quiet while she's speaking. Thank you.
You know, I taught phys ed, I'm used to noise while I'm teaching. But, so my comment is I'm totally in favor of it. I feel like everything they've told us makes sense. It sounds like, for me, I will be paying a little bit more because I'm not on the Medicare plan yet. But to me, the quality of customer service that I had before would make up for it and be well worth it. And also less co-pays, because the co-pays were ridiculous for the Unicare. So that's my comment on that.
Thank you very much. Other questions and comments? No one? Okay. So a reminder, please make sure that you vote before you leave if you're ready to vote. Also, these folks up front will continue to be available for you, and you have a bunch of information in your packets for contacting the benefits administrators. You'll be turning them in outside before you go. And I am now... Yeah, from the folks up here with me, I need a motion to close the public hearing at 8:31. It's been moved and seconded, and all in favor of closing the public hearing at 8:31, say aye. Folks on the right, 8:31, say aye. We already did aye. Thank you. And the public hearing is closed at 8:31. Thank you very much, and this concludes the public meeting also at 8:32. Thank you all for coming.